this is the meta-analysis of antidepressant therapy. As you can see, most of the antidepressants are sitting on or just at the edge of the whiskers. You'll note that not one of the antidepressant studies is positive. The whiskers overlap the zero line for every one of these studies. It's only that at a meta-analytic level, the diamond is a whisker away from the zero bar. So this is at very best a very small benefit of antidepressants, not shown in any individual study. If you look at risk of switch, you see that if we look in acute treatment, there's no effect of switch, but in maintenance treatment, you can clearly see that antidepressants are associated with a much greater risk of switch. So this is a function of time. Now, I'm going to introduce my own bias here. So this is a level 4 bias. But all studies determine only switch to have occurred if you reach threshold mania. If you have some manic features, but you don't reach threshold DSM mania, it is not regarded as a switch. I think that that is wrong, but this is what the evidence base does. So in my view, I think that this meta-analysis and all analyses greatly minimize the emergence of switch by using a bar that is very high. And many people have low-grade subthreshold maniform symptoms. They look a little bit mixed, and that's an adverse effect of antidepressant that is not detected in meta-analyses like this. ECT remains very useful for treatment-refractory patients when you need to do something quickly. Imminent suicide risk, catatonia, severe psychosis, and when you need rapid response for stabilization. And there's efficacy for pre-pulse right unilateral placement. A recent study, here you can see that response at 6 weeks, 73% versus 35%. Remission was a smaller effect size. Adverse events are largely in the domain of memory. Cariprazine is a new alternative for bipolar depression. And here you can see at 3 different doses, they looked at 0.75, 1.5, and 3 milligrams. And you can see 1.75 is not as good as the higher 2 doses. And the higher 2 doses are looking pretty similar. So this is overall MADRS score and CGI score. So this is a new option. And the advantage of cariprazine, as you know, is a relatively benign metabolic side effect profile. Lumateperone, which is another new atypical antipsychotic, very similar picture. It's useful, similar kind of effect sizes to cariprazine. Here's another lumateperone study, a very similar pattern. If you look at MADRS, CGI, and both responders and remitters, you can see an effect of lumateperone as a potential therapy for bipolar disorder. There's another study of non-racemic amisulpiride, which again seems to be useful. There's a very old literature of sulpiride, which is 40 years old, amisulpiride as well in unipolar depression. This is the first bipolar study. The cost with amisulpiride is prolactin. But I want to show you a couple of relatively recent antidepressant studies, which I think are important, which are not in the older CANMET guidelines, but will be incorporated into the newer ones. This is a recent study done by Nasir Gaimi on citalopram versus placebo for depression. And here you can see no benefit of citalopram over placebo. So this is over 6 weeks of study. When they looked at it over time, so this is 12 months, again, no benefit of citalopram, but manic symptoms were greater than with citalopram in the maintenance phase. The bipolar choice and bipolar litmus trials conducted by Andy Nierenberg, he looked at the role of antidepressants versus no antidepressants. And what they found in these 2 studies, when you pool the data, was that antidepressant users had higher CGI, and higher is worse, CGI BP scores at 4, 6, 8, 12, and 16 and 20 weeks. So this is a large study with several hundred patients. Antidepressant using patients did worse than patients not given antidepressants. It's not randomized data, so one has to interpret with caution, but again, a very important recent trial suggesting that antidepressants may not be helpful and might actually be harmful. So when we look at third-line therapies, we have a very long list of agents where the evidence base is weak. All of these are third-line agents and need to be used according to clinical judgment. Some of these agents have major safety and tolerability issues, and some of these agents are very benign indeed.